Hi everyone, good evening. You're all very welcome here this evening and thank you for joining us on what has turned out to be a very nice, surprisingly sunny evening. I don't think we'd been getting the leaving cert weather that we had anticipated so far, but at least it's looking nice this evening. So you're all very welcome to this evening. This webinar will be focusing on older adult mental health, and it is the third instalment in the 2024 GP webinar series, and we're joined this evening by Dr Karen Looney, Dr Aideen O'Neill and Dr Mairead Losty from the Psychology Department here at St Patrick's Mental Health Services. So over the course of the next hour or so, we'll be discussing the evidence base. We'll be discussing, our presenters will be discussing the evidence base for psychological therapies for older adult mental health difficulties, looking at therapies focused on the needs of older adults available here within St Patrick's, while also discussing the broader offering of psychological therapies available to older adults. So before I hand you over to our presenters, I'll just run through some housekeeping very quickly. As always, for those of you who've attended before, you'll know that these events are recognised for CPD points from the ICGP, so they're recognised for 1 point, and those certificates will automatically be sent within the next 4 weeks to any GP who is registered and is attending live this evening. Towards the end of the webinar, then we're hoping we'll have time for a short Q&A. So if you have any questions throughout the presentation or during the Q&A session itself, please do submit them. You'll see the Q&A function at the bottom of your screens there, and you don't need to wait until the end. Just as they pop into your head, feel free to put them in to the Q&A box. I know we've loads to get through this evening between our three speakers, so I'm going to hand you over now to Dr. Looney, Dr. O'Neill and Dr. Losty. And thank you to our three presenters as well for their time this evening.
Thanks very much, Sinead. So as you mentioned, I'm Karen Looney. I'm one of the psychologists here in St Patrick's Mental Health Services, and we're delighted to have this opportunity to speak to you this evening. So if we can just start with the slides, and we will kick straight off with thinking a little bit about, we can go straight to the next slide there, just about the prevalence of international statistics would say about 14% of older people have some kind of mental health issue, most commonly anxiety and depression. About 5.7% of adults fulfill the criteria for depression. This compares kind of reasonably favorably to working age adults, where it's about 5%. For Irish statistics, the most recent ones I could find were from the Tilda study, where it was a bit higher, about 10% of older adults meet criteria for depression, but 18% might meet some criteria but are subclinical. For anxiety, it's a more common picture, with 13% clinically meeting the threshold, and maybe about a third of older adults subclinical. So, which brings us immediately onto the next slide. So you'll be wondering what kind of treatments are going to be useful for adults who might show up to your office talking about their mental health issues. Well, there's quite a strong argument here for psychological interventions. So the World Health Organization have said psychological interventions can be highly effective for many mental health conditions, particularly anxiety and depression. Nice guidelines around depression in adults. It does say do not routinely offer antidepressant medication as a first-line treatment for less severe depression unless it's the person's preference. And of the 11 suggested treatment options for first-line treatment for less severe depression, 5 of these are psychological therapies. Just 1 is medication. The other ones are things like group exercise, mindfulness, guided self-help, and so on. And for first-line treatments for more severe depression, 4 out of the 10 recommended treatments are psychological therapies. 1 option is medication, and the most highly recommended option is a combination of both. In relation to anxiety, the NICE quality standard on anxiety disorders says evidence-based psychological interventions can be effective treatments for anxiety disorders, and they are recommended as first-line treatments in preference to pharmacological treatment. So you may be thinking, well, that's all great for kind of working age adults and adults in general, but what about older adults who, you know, are they going to respond to therapy in the same way, or less? Is it going to be less effective? Many older adults may not ask about therapy when they come to your office. So on the next slide, we can see that there is a very strong evidence base to support the idea that older adults not only respond well to therapy, but actually have they actually have a better response to psychological therapy than working age adults. So these are 2 really large studies that have been carried out in the last few years that show very similar findings. If you just want to go on to the next slide. So in the Chaplin et al. Study from 2015, huge ends there, comparing adults to older adults in terms of their response to therapy. And older adults were 50% more likely to complete therapy. There's a higher proportion of older adults who make a recovery, and there's a higher proportion of older adults who make a recovery or reliable improvement compared to working age adults. In the Saunders study, a little bit more recently, which used data from the IAPT services in the NHS in the UK, again, pretty large ends there. They did say that older adults maybe had less severe mental health problems at baseline, but even when controlling for this, the results showed that, again, older adults more likely to reliably recover, older adults more likely to reliably improve, and having a long-term health condition was associated with a lower likelihood of reliable recovery, but only for working age adults, and this had a much a less significant effect for older adults. So the evidence is very clear. Older adults can and do respond well to psychological therapies. And when you couple this with what we're going to see on the next slide here, which is what's known as the aging paradox, where this is essentially a kind of highly replicable effect that's been found in study after study, that when you ask people to self-rate their levels of happiness and contentment with their lives, and you do this across different age cohorts, you'll find that young people will, rate themselves as reasonably happy and so on, and the self-ratings decline to midlife, and their kind of lowest point is around 48 or age 50, and then it starts to improve in later years. And this is study after study. So the graph you're looking at there on the left-hand side is from a meta-analysis done by Blanche Flower. This is just one of multiple figures that are in that study. This is UK data. The green line is people were asked to rate how worthwhile you feel your life is. The blue line is how much satisfaction do you have in your life, and the red line is how happy are you. And you can see it starts on the left at age 16 and goes to age 68. And you can clearly see that U-shaped curve. Now, in his meta-analysis, Blanche Flower says his conclusion is no ifs, no buts, well-being is U-shaped in age. But one of the criticisms of this kind of research is that, not enough older people in their later life have been studied. So this is a more recent study here in 2022, where they had 4 age cohorts, and the 4th age cohort there was from age 70 through to 99, in fact. And interestingly, in this study, where the longer line is where people were asked about life satisfaction, the more broken up line is where they're asked to rate their happiness in this moment. In fact, we're not even really seeing the kind of U-shape where younger people are not really rating themselves as that happy. But clearly, the older people get, the happier they are and the more life satisfaction they have. So taking that together with the evidence for the effectiveness of psychological therapies, really, it's really important to hold in mind that if an older person comes to your office and they seem unhappy, they seem depressed, this is not normal for older people, okay? And there's a lot of help available. Now, having said that, on the next slide, it is important also to acknowledge that there are barriers to kind of engaging older people in psychological therapy, both in terms of referring older adults to mental health services in the first place, and even from within mental health services, then engaging older people in psychological therapy. And a lot's been written about this, and it seems like the barriers exist at numerous different levels. So both at the level of the older person themselves. So some research has shown older people might have beliefs like, I shouldn't need help, or I just want to help myself in my own way, and so on. And this may prevent them discussing their mental health difficulties in the first place. Some of the barriers may exist with service providers of various kinds. And again, there's a lot of research done on this, showing that there are various kind of aging effects here. So, for example, when doctors are given case studies of 2 identical patients describing the same symptoms of depression who only differ in age. So in the study, they were aged 39 and 81. The diagnoses and treatments prescribed for the younger patient were significantly more appropriate than for the older patient. And it's not just doctors, because also psychologists and counsellors, when presented with fictitious cases, they rated the older people as less able to create a therapeutic relationship, having poorer prognosis, and being less appropriate for therapy compared with younger patients with the same symptoms, and so on and so forth. And amongst GPs in the UK, that last study, they found that referrals for therapy and prescriptions for antidepressants were significantly less likely. The final study there is that older adults who self-harmed, despite high risk of suicide in this group. And there can be lots of reasons for this, but we could probably sum a lot of them up with the sense that we live in an age of society, and none of us are immune to the effects of those kind of biases that can creep into our practices. And I include myself in that, absolutely. So on the next slide, it's worth just thinking very briefly about how to engage older people in conversations about their mental health. I guess one way in is to think about the links and open up a discussion about the links between our physical health and mental health and how they're interconnected. We're very familiar with the idea that, stress can play a role in lots of physical health issues, and, stress is part of our mental health, and that might be one way in. It might be useful to use something like a brief screening measure. The one that's mentioned in this paper is a 2-question screening measure that you can kind of weave into a conversation about mental health. The first question is, have you been troubled by feeling down, depressed, or hopeless? The second question is, have you experienced little interest or pleasure in doing things? It wouldn't take a lot to just weave that in. Obviously, it's important to reflect back and validate what you've heard in a person's story. It's understandable they've been struggling and so on. And it's probably worth thinking about saying something about stigma and reducing stigma, because although, it does seem like there's less stigma now, but certainly for older adults coming in, they would have grown up in a time where there was much more severe stigma and the kind of threat of institutionalization was much stronger. So reminding the patient that mental health difficulties are very common, and that services are better now, and the understanding about mental health difficulties is much better now than it used to be, can be helpful. So I'm just going to go on now and tell you a little bit on the next slide about the psychological therapies on offer in St. Patrick's Mental Health Services. So just flipping over to the next slide there, please. So all of the programs that we're going to tell you about this evening are obviously open to older adult service users who are already under the care of St. Patrick's Mental Health Services. But we're very pleased to announce this evening that we are now open to receiving referrals directly from GPs. And we would really welcome those referrals. So typically programs are covered by health insurance. This is something that's checked at the point of referral. Typically they are kind of once a week attendances on campus here, but we're also able to facilitate remote attendances through some of our hybrid technology. And we're lucky to be supported by a fantastic team of service user, IT support, kind of experts who are very committed to helping older people get connected to the internet so they can attend remotely. We obviously welcome people who might be inpatient for a while and day patient attenders, and usually sessions are run once a week. And on the next slide then, just the practicalities about referring. So referrals are accepted from the form that's downloadable from the website, or through HealthLink, or whatever your GP practice IT management system is. You can mark the referral older adult psychology day programs, and essentially what will happen is one of the team of psychologists, including ourselves, who work with older people, will offer your potential service user an assessment appointment, and we'll clinically assess which program might best meet the mental health needs of the service user. And if something other than one of our programs is recommended, then obviously we'll communicate this as well to you and to the service user, for example, something like individual therapy. And just to say, clinical responsibility remains with the GP referrer for the duration of any program that a service user might attend. So on the next slide there, just to introduce, we're going to tell you now about the 3 programs that are now accepting direct referrals: the Living Well with Mild Cognitive Impairment program, compassion focused therapy for older adults, and then at the end I'll be speaking about the SAGE program. So at this point I'm going to hand you over to my colleague Aideen O'Neill, who's going to tell you about the Living Well with Mild Cognitive Impairment group.
Thanks, Karen. So I'm just going to spend a little bit of time talking about our new psychological program for individuals with mild cognitive impairment. So we've just finished the first cycle of this program here in the hospital. So just before I go into what the program covers, I might just kind of do a quick recap on kind of what is mild cognitive impairment, and the NHS have a really helpful video kind of a guide to the public around this, and this is something that we show our service users. So I might just ask Katie or Sinead to share that video there.
I'd become increasingly bothered that I was forgetting things, mainly how to do things.
Well, I knew there was something wrong before I went. I could feel the stopping, and it was irritating.
If we were having a conversation and Larry was telling a story, he'd get to a word and then he would just stop and try and drag the word out, what he wants to say. And then he'd look at me probably and I'd suggest a word that, you know, to fill in.
So mild cognitive impairment is a condition where people have an impairment of their cognition, but it doesn't affect their function. Cognition means their thinking. Thinking occurs in different areas. So it might be, for example, that they can't find words, or perhaps they have an impairment of their memory, so they can't remember certain objects or items, or it might affect some of the skills that they want to do. But it's different from what they were, so there's been an impairment, but it's not so bad that it's affecting their day-to-day activity.
Commonly, it's about forgetting conversations or misplacing things.
If you're worried, then the main thing to do is to see your GP to get a diagnosis in the first instance, because although people are afraid of the diagnosis, the sooner that you get the diagnosis, the sooner you can get support.
If a patient or their relatives feel that someone's actually having some memory problems greater than what they were, or they're having some difficulty, then speak to your GP. It may be that they have mild cognitive impairment, and if we can recognise it early, then we can plan their treatment and management early.
We know people with mild cognitive impairment, many of them will go on to develop dementia, but some won't go on to develop dementia. So there is a balance there about helping people understand what the diagnosis is, supporting them with the anxiety and the uncertainty of what the future holds, and giving them some tools to deal with that.
I would say to other people that if they've got any worries, to go to their own doctor and get help.
Just having the initial diagnosis made a huge difference to me. I thought, well, because you almost feel as though you're going mad. And I just almost went, whew, thank goodness there is something wrong. You know, it's just not my imagination. Yeah.
We cope with it all right, but we know now that if we have got any worries, there are people, we've got phone numbers to phone, people to talk to, if we've got any worries whatsoever.
Thanks. So yeah, I suppose that video is one that we kind of feel is helpful for kind of service users and professionals as well, just to kind of get a sense of what MCI is. I suppose the BPS definition of mild cognitive impairment is that it's characterised by a change in cognition recognised by the affected individual and or kind of observers, objective impairment in one or more cognitive domains, some difficulty with functional activities. However, again, the person will be kind of largely independent in this area in their lives, and the absence of dementia. And deficits are not attributable to another medical or psychological condition. And I suppose that that's an important piece around MCI that I think a lot of people aren't kind of so sure about. That so MCI is kind of different to dementia, and it can for some people progress into dementia. But I don't know if you noticed in the video there's a lot of kind of competing figures in the research around that. So even in that video that we watched, the figure was 6 to 12% of people with MCI will go on to develop dementia. And then later on, somebody in the video says many people will go on to develop dementia. And this is kind of what's reflected in the research. I suppose the figures around this are a bit uncertain, and they're a little bit kind of different depending on kind of what research you read. And that's something that can be kind of, I think, tricky for service users as well, who just received the diagnosis. So we might just go on to the next slide there. So how does MCI impact on people's lives? There's a huge emotional impact for people. So we often find there's an increase in anxiety, in depression, and just a decrease in kind of overall psychological well-being, and a lot of kind of worry and low mood, obviously kind of, and hopelessness related to the diagnosis. It can impact people practically, so they might find that they're kind of struggling day to day with their daily activities. So again, while they remain kind of largely independent in that, they often do notice that they're struggling with kind of completing tasks that they would have always completed, or kind of doing things that they're interested in, activities that they enjoy, or kind of living independently. And then there's obviously an impact cognitively, so kind of our thinking, memory, language, attention, orientation, etc. And I suppose another piece around MCI is that it's quite a heterogeneous kind of diagnosis. So it can look differently for different people. So for example, there is kind of amnestic MCI. There's also non-amnestic MCI. So for people with MCI whose memories actually aren't impacted, but it could be more in their attention or kind of executive functioning or kind of organization planning and that kind of thing. So this can look really different for different people. Might just go on to the next slide there. So our Living Well with MCI program is, again, it's a new program that we recently kind of started and completed the first cycle in the hospital. So it's a group program that offers support for people with managing the emotional, cognitive and practical elements of the diagnosis, as well as offering support to their carers and loved ones. So this program incorporates psychological coping skills and cognitive rehabilitation strategies, and kind of just general memory and attention kind of compensatory strategies, which are designed to support people with cognitive impairment to achieve important goals and maximize their cognitive abilities. So kind of thinking about goals for each person and kind of how the diagnosis is impacting their lives, and the areas that they'd like to receive support around is important as well. I might go to the next slide, thanks. So in terms of intervention, the BPS would recommend interventions that include kind of space for kind of psychological adjustment to the diagnosis. And I suppose this would be something that would be common across a lot of different diagnoses, that, you know, it can be a shock to receive the diagnosis, and people often aren't sure what it means and what the prognosis is. So that the intervention would kind of hold space for that psychological adjustment piece. Input on managing stress, anxiety and depression. And again, we'd see that really commonly, especially within the first kind of few months of the diagnosis. People can be really, really worried and concerned about it, and worried that it will lead to dementia, or that things will kind of go downhill from there. Kind of improving and maintaining cognitive function through a number of different types of therapies. So there's cognitive rehabilitation therapy, cognitive stimulation therapy, which kind of up until more recently was often seen as, I suppose, to be used just for people with dementia or kind of with more severe cognitive difficulties. But more recently, there is evidence that cognitive stimulation therapy can be helpful for an MCI population as well. And cognitive training is another kind of technique that that has been found to be helpful for people with MCI. And then also that the intervention would offer support for families and caregivers too. Okay, and yeah, I suppose again, just kind of emphasising that I suppose an appropriate intervention here would combine, would look at activities that combine kind of cognitive, social and physical exercise and activities, and these are likely to be the most appealing kind of combination of interventions for people with MCI, and that there's some evidence that interventions like this would lead to a reduction in dementia risk as well, so maybe making it less likely that the person would progress to something more severe. So in terms of what our programme covers, so we really kind of have looked to that guidance from the BPS and from the existing evidence base, and our programme is an 8-week programme, so we have 8 group sessions, and we've 1 midway individual review session as well. So after the first 4 group sessions, we meet with everybody individually, and just to kind of check in and see how they're finding the group, and also just to think about kind of individualized goals as well, and in terms of kind of what strategies would be helpful for them and what particular goals they'd like to work on. So we cover the following: psychoeducation, so helping the person to learn about MCI, and again, it's a diagnosis that there's a lot of confusion about, even sometimes within professionals, so giving that bit of space to kind of give some education about the diagnosis is really helpful. Learning and teaching strategies to compensate for the difficulties, looking at some cognitive stimulation tasks. So kind of what we bring into a group are things like kind of games, discussions around kind of current affairs. So things that are a little bit kind of novel and new for the service users, just to help kind of stimulate new neural connections. Talking about lifestyle and how this can be adapted to help people with mild cognitive impairment. And then we have a session with carers and loved ones as well. So some of the strategies that we look at, so we look at kind of general memory and compensatory strategies. So Michelle Hamill has a kind of program designed for people with MCI that kind of would give some general kind of guidance on compensatory strategies. So things like kind of having a place for everything, and you know, strategies to kind of help with our attention, which is obviously a huge part of kind of memory. We also incorporate some cognitive rehabilitation strategies. These are a little bit more kind of individualized. So we have kind of broader strategies that kind of everybody could apply. And then we look at kind of maybe some more individualized strategies. So kind of looking at certain tasks that the person struggles with, for example, kind of turning on the computer, using their phone, things that they would have kind of always been able to do before, and just giving kind of some specific guidance and intervention around that. And then, as I said, kind of bringing in some cognitive stimulation therapy techniques as well into the group. So I might just, I suppose, go into the evidence base for cognitive rehabilitation. So I suppose, firstly, cognitive rehabilitation is the use of any intervention or strategy or technique which enables clients or patients and their families to live with, manage, bypass, reduce, or come to terms with deficits that are precipitated by injury to the brain. And I suppose what's important here, and it's something that we often kind of, we try to make sure that we manage expectations with service users, because they often have some hope that maybe the strategies we teach can reverse difficulties or can kind of, you know, make things go back to the way they were before. And I suppose we try to be quite clear that the strategies are more around kind of compensating for existing difficulties, maybe finding new ways to kind of engage in tasks that they would have engaged in before. So it's not on enhancing performance or maybe kind of things going back to the way they were, but just improving functioning in the everyday context. So I suppose there is evidence that kind of even for people with kind of early stage Alzheimer's or dementia, that there is some cognitive and neural plasticity preserved kind of in those early stages, and that there's also a capacity for new learning. So even in people with kind of Alzheimer's and dementia, so even for people who have progressed past MCI, there's evidence that actually new pathways can be built and new habits can be formed. And we think that's really important, because often service users, and again, sometimes professionals, can kind of believe that this diagnosis is, you know, that there's kind of not really much hope here and things are kind of going to go downhill from here. And it's about kind of just trying to manage the difficulties. But we do know that there is some hope, and kind of even research around kind of functional plasticity. So brain function can move from damaged to undamaged areas of the brain, and there's a lot of potential here. So and there's a lot of new research around this area. So I suppose there is hope, and there's new learning can occur. So cognitive rehabilitation can help individuals and their families to maximise remaining memory ability by identifying the best ways of taking in important information, so kind of focusing on attention and encoding of information, develop strategies for learning information via less impaired components of the memory system, and then by carrying out important real-life practical skills as well. It assists participants in developing ways to compensate, again, for impairments in affected memory by using things like external memory aids. So that's a huge piece. How can we kind of reduce the cognitive load? You know, if I'm somebody who never had to use a diary, and this comes up a lot in our group, kind of how people used to function before, and maybe people could function quite well before and not have to use that many memory aids or things like diaries or kind of notebooks or, you know, whatever memory strategy they have to use now. So it's about kind of encouraging them to do that, even if it's something I didn't have to do before. Now it's about kind of reducing that cognitive load, making environmental changes, and minimizing cognitive demands of various activities. And then just briefly on cognitive stimulation. So an important part of keeping our brains healthy is developing new connections and associations. And we do this in our group through cognitive stimulation therapy. So again, this involves playing games, having discussions about kind of current news affairs, or just facilitating thinking about things in a new or a different way. And even for a lot of our service users kind of coming into the group and kind of traveling into hospital, meeting a group of new people, these are things that maybe they wouldn't have done for many, many years. So even that alone is kind of quite stimulating. And we hold in mind kind of when we design our content, you know, is the content visually stimulating? Can we kind of try and activate a lot of different senses here? Because this will kind of stimulate new neural pathways as well. So in terms of how we teach these different strategies, so there's the first part, which is acquisition, so explaining these strategies, explaining new strategies and how they can help, and then application, so helping the service users to think about and to plan how to use these strategies in their daily lives. And then the third piece, adaptation, and this is where they have to practice these strategies outside of the group and outside of the hospital. I suppose this is a piece that we can't directly support service users with, but we can kind of help them to plan how to do that. And kind of getting family involvement here as well can be really helpful, just so that there's kind of prompts in their environment at home too. We, I suppose, spend a little bit of time speaking to service users about the impact of stress on our cognition. So a lot of service users who come to our group are experiencing quite a lot of stress related to the diagnosis, and related, I suppose, to the impact of the diagnosis on their lives, especially earlier on. So in the first kind of couple of months after they've received the diagnosis. And we explain a little bit about how stress can affect how memories are formed. It's more difficult to learn when stressed, and it also has an impact on how we retrieve memories or remember information. So if you're looking at the different parts of memory there in that diagram, stress can really impact that kind of first kind of paying attention and encoding. So if I'm stressed and worried, it's really difficult to pay attention and kind of take in the information that we want to remember. And then it can impact a lot in retrieval of information as well. And a lot of our service users would kind of get very worried when they notice a cognitive deficit. They notice they can't remember a word or remember something that they want to. And the stress and anxiety of that actually makes it more difficult to access the memory. So we give a good bit of education around that. Yeah, and that's kind of more the same. So I might just go on to the next slide there. Thanks. We speak a little bit as well about the importance of positive emotions. And I suppose we don't kind of discourage service users from feeling kind of emotions that are seen as a bit more negative, like anger, sadness, fear. They're all really important, and they're an important part of the diagnosis, and actually encouraging service users to tune into those and express them in the group setting can be really helpful. But oftentimes when we're feeling kind of worried, or we're feeling angry or sad or upset, that can kind of activate our sympathetic nervous system, and that can make it difficult to think kind of logically. It can shut down, you know, if it's very intense worry or stress, it can kind of shut down the prefrontal cortex for a while, and thinking becomes really difficult. Whereas there's some research around positive emotions, things like happiness, comfort, contentedness, pleasure, they can help to kind of regulate the nervous system. And when we're feeling those things, we tend to be a bit more kind of open and curious and kind of cognitively flexible. And then that helps us to kind of learn new things. So that's another kind of piece that we think it's important for our service users to know. And we talk a lot in our group about kind of how to kind of regulate and manage difficult emotions, and maybe how to move towards those more positive emotions. Social interaction, I suppose, as well, is also a very important piece for emotional well-being. It improves mood, and it's cognitively stimulating. So again, for our service users, even just coming into the group and meeting new people, that can be really important for them. Okay. Yeah, that's a little bit, I might skip on to, I'm slightly conscious of time, so I might skip on to the next slide. And then we give a little bit of education just around lifestyle factors and MCI as well. So kind of just general advice on things like kind of physical activity, cutting out smoking, alcohol, the importance of a healthy diet, engaging in kind of cognitively stimulating activities, social engagement, sleep, and just kind of general mental health, kind of minding our mental health. And we do get families and carers involved, so they come in for one session, and we're thinking about for the next cycle maybe bringing them in a little bit more often. But kind of carers and family involvement can aid in just the generalisation of some of the strategies learned in group. And research in this area outlines that actually it's really important for family members or caregivers to kind of get their own support, and there's an increased need for that, especially as their loved ones' kind of level of difficulty increases. And we discuss helpful concepts in groups such as kind of validation, and that can kind of help with relationships as well. And then finally, psychological adjustment is something that I suppose this is something that came out of the first cycle. Our group programme, I suppose, tends to really help service users with that process of adjusting to the diagnosis. And I suppose we normalise that things like kind of shock and anger and sadness and hopelessness and bargaining and all of those things can come up, and it's not a linear cycle. It's, you know, we might kind of one day be feeling a little bit more accepting, and then the next day we're kind of back to feeling anxious and angry maybe again, or frustrated. And this is all a normal part of kind of adjusting, but eventually we get to a point of actually accepting the diagnosis, and this can kind of open us up to maybe then looking at some of the strategies that can make life a little easier. So just quickly, some observations from our first cycle. So just that uncertainty piece, the uncertainty of the diagnosis and the kind of the future, I suppose, and what the future holds for service users seems to be one of the most difficult parts. Almost all service users named the impact of anxiety and self-criticism on their cognition. So just kind of noticing that the more worried they were about their cognitive deficits, and the more kind of they gave out to themselves or criticised themselves for that, that I suppose that negatively impacted on their cognition. And then almost all spoke about finding it hard to put the new strategies in place, because actually they had some difficulty accepting the diagnosis and accepting that they had to alter their old habits and try to kind of look at new ones. And then just some feedback from the first cycle. So I won't kind of go through it all, but just things like, I'm glad I did it. It helped me get a handle on what's going on and what's happened to me. A lot of people spoke about kind of experiencing reciprocal empathy from others and kind of support from others. Kind of talking about the atmosphere, that it wasn't kind of probing, and they felt kind of safe and comfortable. And that actually seemed to be the majority of feedback that we got was around the group process and kind of feeling safe and comfortable in the group, rather than maybe the strategies themselves. So that's something we really kind of took away, that people who've received this diagnosis really value being able to kind of talk about it, being in a group of others who have the same diagnosis, and just getting that bit of education as well, and being able to express kind of worries and concerns. I think that's me. So I might hand over to Mairead.
Thanks, Aideen, and hi everyone. So yeah, I just wanted to talk about our kind of compassion focused therapy for older adults group. But before talking about that, I just wanted to talk a little bit about self-criticism and older adults. So when I talk about self-criticism, I'm meaning an internal dialogue where we judge ourselves harshly, focusing on our perceived flaws and our mistakes and inadequacies as well. And that might be what's coming to your mind when you think about that idea of self-criticism. You might even be thinking about, patients that you see who might be quite critical of themselves, maybe say things like, oh, I'm being so stupid or silly, I'm making a mountain out of a molehill. Patients who might feel a huge amount of burden or feel like, they're being kind of burdensome on their family and hold a lot of kind of guilt and shame around that as well. And we know that self-criticism, it can lead to feelings of shame and guilt, and it can underpin mental health difficulties such as depression and anxiety. There's also kind of evidence to show that older adults might be vulnerable to experiencing self-criticism, and its associated feelings of shame and guilt. So we know that as people age, they might find it harder to engage in everyday activities, and they might need to depend on other people more, and they may experience, multiple losses. They might be noticing changes in their physical body and their abilities. They might notice changes in cognition, as Aideen has spoken about. And they may have to experience much more losses as well. People in their life, loved ones passing away, and these experiences can make an older adult more vulnerable to experiencing self-criticism and to shame and guilt. I might ask you just to move to the next slide. So I suppose we were holding all of that in mind, and we wanted to develop a group that was specifically for older adults and older adults who were experiencing high levels of self-criticism. And compassion-focused therapy is a therapy that's been developed specifically for people who experience high levels of self-criticism and shame. So CFT, just to tell you a little bit about that, it's an evidence-based psychological intervention that was developed by Paul Gilbert. And it's really been developed, as I said, specifically for people who experience high levels of self-criticism and shame. So it draws upon, evolutionary theory about what we know about how the brain develops and the role of emotions, how we've learned to cope and survive with our lives. And it's using that information to understand self-criticism, why it has developed in someone's life and the function that it's trying to serve for the person. And with that understanding, it's trying to help the person to start to change the way they relate to themselves. So rather than relating to themselves with self-criticism, to bring in more compassion into the way that they relate to themselves. And CFT has been shown to be helpful with a range of issues, including anxiety and depression. There's not as much research with CFT for older adults, but there is kind of an emerging evidence base there that this could be a useful intervention. And certainly that's what we're finding with the groups that we're running. So I ask you to move to the next slide there. So really at the heart of CFT, as the name would suggest, is compassion. And in CFT, we define compassion as a sensitivity to suffering in ourselves and others, along with a commitment to try and alleviate and prevent future suffering. So in CFT, it is a process of turning towards suffering, turning towards the past, and trying to make sense of how that's really shaped us. And CFT, it really contends that, there's so many experiences that are outside of our control, and things that we're exposed to that we don't get to choose. And we don't get to choose our family or the country that we were born into, the time in history that we were born. But all of these experiences, they can really shape us. They can shape the beliefs that we hold about ourselves and other people and the world, and they can inform self-criticism. And if we can turn towards that and understand it and make sense of it, then we can start to soften some of the beliefs that we hold, some of those beliefs that are leading us to suffer today. And we can start to soften self-criticism as well and turn towards a different way of relating to ourselves, a more compassionate way of relating to ourselves. And that really is the goal of CFT. So if you can flip to the next slide there, that would be great. So that brings us on to our CFT group. So we've called it the Compassion Focused Therapy for Older Adult Group, or CFTOA as we call it. And I want to ask you to move to the next slide there. So our group is for older adults, so 65 years and older, who are experiencing mental health difficulties either for the first time or currently, who identify with self-criticism and shame, who struggle to feel relieved, reassured and safe. So we know that people who experience high levels of self-criticism, they can really find it hard to connect to an internal sense of safety. And can also find it hard to feel safe in being vulnerable with other people as well. It's for people who are experiencing difficulties receiving compassion from others and offering self-compassion as well. And it's for people who are open to engaging in a group psychological therapy program. It is a group exclusively for older adults, and some older adults might not want to be in a group with other older adults. So if that's the case, our group will not be for your patient, but for people who really want to be around other older adults, and people who are experiencing similar difficulties with them. Our group is a good fit. So if you can move to the next slide there, that would be great. So what we do in CFTOA, well, we aim to generate feelings of connection and safety amongst group members. So as I said there a short time ago, people who experience self-criticism can find it very hard to connect to an internal sense of safety, and can find it hard to really share and be open with others people as well, and to talk about maybe experiences that they've had that have been incredibly difficult for them. So what we do in our group, particularly at the start, is really focus on trying to create a sense of connection amongst the group and create a sense of safety amongst the group, so that each group member feels more able to turn towards experiences from the past, so that they can start to make sense of how those experiences have really shaped them. So there's a real emphasis on that in our group. And then we also explore and teach ways to work with our pain and suffering. And that includes attributes and skills associated with compassion. And on the next slide, there's just a visual that kind of shows some of the things that we're kind of working towards in CFT, in our CFT group. So we're looking at things like developing a sense of sympathy, of sensitivity, a care for well-being, creating that kind of non-judgmental space. We also look at distress tolerance. So for some people who experience self-criticism, they might also, their critic might tell them that they have to put other people's needs ahead of their own, that they can't ask for help. So when we're asking them to try something different, to maybe ask for care themselves, to maybe put in boundaries around how they're caring for other people, it can trigger a sense of discomfort, and it can trigger feelings of guilt. So being able to tolerate that distress is really important when it comes to moving towards a more compassionate way of relating to themselves. We also do different skills. We use imagery, we use breathing practices, and imagery practices like allowing someone to be able to create their own safe place that they can use to then connect to that sense of safety within themselves. We look at kind of bringing mindfulness and reasoning and behavior, engaging in compassionate behaviors. And we would do a lot in group of focusing on how people are being compassionate towards each other and what it's like to receive compassion from others as well. There's some of the things that we do in our CFTOA group. I might ask you to move to the next slide there as well. So some of the practical details, so it is a closed group, and so people don't join the group kind of halfway through or anything like that. So the people who are there at the start are there towards the end as well. It's an 18 group session, so it runs once per week, and there are 2 individual sessions at the midway point, and at the end of group as well. And really the intention of them is just to check in with each group member, see how they're finding the group, see what they're noticing, thinking about what their hopes might be, and even towards the end of the group, what they feel might be helpful as a next step. It's a 3-hour group, but there's a 30-minute break at the midway, and it's a face-to-face group, so it happens in St. Patrick's Hospital. If you can move to the next slide for me there, please. So I think one of the kind of biggest selling points around CFTOA is really the feedback from our service users. So the group, it started as a pilot in 2022, but because it had such good feedback, it's now kind of a permanent staple. And this is just some of the feedback that we've gotten. We've just finished our 2nd cycle of the group. And so I'm just going to read this out. So I feel I benefited not only from the input of the psychologist in each session, but also from the wisdom and response of other group members. I felt the group was very beneficial, more than expected, to the interaction with other group members. I felt comfortable to discuss difficult experiences that affected me since childhood. I feel more confident and worthwhile as a person. I can get better with dealing with everyday issues and accepting that I can't undo the past. And if you could move to the next slide. So group was extremely beneficial to me. It was thought out very gently and warmly by the psychologist how much we need compassion for ourselves. All of us in group gel very quickly and show compassion for each other. And then just the final piece of feedback here, the group was very beneficial to me. It helped me to become more compassionate, confident, assertive, and it let me see all the bad things that happened in my life were not my fault. So really, I think that final comment, all of the comments really are highlighting what our intention is in the CFTOA group. And I think really the feedback is the biggest selling point for compassion-focused therapy and how it can be so useful for older adults who are struggling with self-criticism and who are struggling with mental health difficulties connected to that. And so thank you for listening. And I'm going to pass you over to Karen now.
Thanks, Mairead. I'm falling prey to the evening sun here a little bit, so I hope you can see and hear me okay. So I'm conscious of time, but I'm just going to really quickly tell you about the final program, which is the SAGE program, and then I'm going to sum up at the end again, just about the practicalities of referring people to the 3 programs. So the SAGE program is a 19-week closed group for adults, older adults whose mental health difficulties are associated with over-control. So over-control is a transdiagnostic construct linked to a range of mental health problems, such as kind of chronic depression and anxiety, various sort of personality disorder type traits, if you want to use that kind of language. And we might just skip over the next slide and go to the one after it. Perfect. So essentially, what we're sort of, the kind of underpinning model here about over control suggests that there are certain kind of nature elements to do with high threat sensitivity and low reward sensitivity. So certain temperamental features from a kind of a biological point of view that interact with certain kind of key experiences in early life generally, but it could be at any point in somebody's life experience, where there are certain kind of messages imparted about keeping up appearances, always achieving highly, mistakes are intolerable. The phrase that we hear so often from older people, which is you just get on with it, and being brave and strong. And if you kind of absorb enough of this, and you have a certain kind of temperament, it can lead to a particular kind of coping style, which is referred to over control. And this is essentially where people have learned to inhibit their emotions a lot. They'll always say they're fine, where they have a high level of need for control, or might be seen as kind of rigid and perfectionistic. And their relationships tend to be a little bit aloof and distant. They struggle to be kind of authentic and intimate with other people. And all of this leads to the core problem of over control, which is emotional loneliness, or as a colleague once described it, it's sort of prioritizing protection over connection. So because this is associated with a range of different mental health problems, it's this style that we target in the SAGE program. So if you want to just go on to the next slide there. So in a nutshell, those three kind of main themes in the way somebody might cope, we target those in group. So we, through weekly sessions that involve sort of skill training and experiential exercises and various other things that happen in group, we try and support people to increase their emotional experiencing and expression. We support people to increase their psychological flexibility and openness to experiences. And we support people to increase their social connection within group and then outside of group as well. And on the next slide, you can see that the data we've been collecting kind of supports that is in fact what's happening for people. So there's a reduction in mental health symptomatology by way of depression, anxiety, and stress. People report less need for structure and rigidity, and less need for emotional inhibition. In other words, an increase in emotional expression by the end of group. And again, the numbers are all kind of great, but really it's all about the participant feedback. Here's on the next slide. And just for the sake of time, I'll just cut to on the very last one there, which is my favorite one, which is you could only be better by participating in it in a way it was a life changer. So on the next slide, just a couple of practicalities. So it's a 19-week group, 18 group sessions, 1 individual midway review session. We also run a no commitment taster session before each cycle where potential participants can meet the team, see what it's like to be in a group, learn more about what the program involves, and have the opportunity to speak individually to the team as well, so they can make a kind of a fully informed decision about whether this is for them. So just to sum up then, on the basis of kind of everything we've spoken about between the three of us here this evening, really what we want you to take away is that psychological therapies have a strong evidence base for older people and are recommended as treatments for a range of mental health problems. There are 3 psychological therapy programs on offer for older adults in St. Patrick's Mental Health Services, and we are now welcoming referrals directly from GPs, which you can direct them to older adult psychology day programs on your referral forms. And the psychology team, so that my 2 colleagues and myself and some other psychologists who work with us as well, will assess any person who's referred from yourselves and see which program you feel might best meet their needs. And if none of the programs meet their needs, that will be communicated obviously to the service user and to yourselves with whatever other recommendations we might make, for example, such as things as individual therapy. And that is it from us. So we'd welcome any questions that you have. Thank you for your time.